are moving on to yet another session on oral hypoglycemic agents, SGLT2 inhibitors. These are the blockbusters molecule of the last 10 years. We have been using this molecule exactly for about 10 years. When we talk about SGLT2 inhibitors, all that it comes to our mind is it is all flooded by lots of data. So as we were discussing about the DPP4 inhibitor, that was the time the cardiovascular outcome trial was made mandatory for those molecules. But when it came to SGLT2 inhibitors, almost all the molecules which had hit the market came with its own cardiovascular outcome data, either before the launch or after the launch. It was varying. But when we talk about SGLT2 inhibitors, it is all data. And what we are going to see, say for the next 1 hour or so, is about how SGLT2 inhibitors, what are their mechanisms, how it all got evolved, how to place it, what do we need to know about this molecule. But we have to know little bit of data also. So I will make these data very, very simple. Will not bore you with lots of charts and graphs. But at the same time, we need to know about the various studies which have done in this field also, means in the field of SGLT2 inhibitor evolution. So we will just move on. When we talk about SGLT2 inhibitors, this is the famous difference thesis on ominous acted, when the pathophysiology was moving from 3 things to 8 things. We always had this increased glucose reabsorption. Though we had this increased glucose reabsorption, but we were not seeing or not discussing about this till about say 2012 or 2011. So just a passing by mention was about increased glucose reabsorption, because we couldn't do anything on any molecules whatever be available at that time till 2012, be it either metformin, sulfonylurea, DPP4, AGI. None were able to address this pathophysiological mechanism. But we know like this is attributing it. But we were never talking about increased glucose reabsorption at all. So only after the advent of SGLT2 inhibitors, this particular pathway came into limelight. So this is something which was existed even before the SGLT2 inhibitors came into the market, but we were not discussing much about that at all. Now, as you see in this cartoon, like this cartoon will tell you like how it happens in a healthy condition. So there are about 180 gram of glucose that gets filtered per day. In healthy individuals, the renal glomeruli filter 180 gram of glucose per day. So the glomerulus filters this much amount of glucose. But what is important is virtually all the filtered glucose. So the glucose which is getting filtered from the glomerulus like this, all this glucose is reabsorbed in the proximal tubules, either through this SGLT2 receptors or through this SGLT1. So what are this SGLT and SGLT1? They are the sodium glucose transporters 2 and 1. So these SGLT2 receptors, they account for, SGLT2 account for 90% of the glucose that gets reabsorbed, which is getting filtered from the glomerulus. And these SGLT2 receptors are predominantly present in the proximal convoluted tubule in the S1 and S2 segment, whereas the SGLT1 receptors are present in the S3 segment of the proximal convoluted tubule. So SGLT2 accounts for 90%. We will see why it accounts for the 90% and why SGLT1 accounts for 10%. So this is the reason why almost all the glucose that is getting filtered from the glomerulus is reabsorbed from the proximal convoluted tubule, and we are not able to see any glucose which is available at the distal convoluted tubule or in the urine for that matter. So no glucose reaches over there, because most of it which is getting filtered is getting absorbed. So that is how mechanism happens in a normal healthy individual. The difference between this SGLT2 and SGLT1 receptor is SGLT2 receptors are present mainly in the kidney. So they have the presence of SGLT2 receptors in the kidney is higher, whereas the SGLT1 receptors as we saw earlier, it is also present in the kidney, but apart from the kidney, the main place where it is present is in the small intestine, heart and brain. So these are the places where SGLT and SGLT1 receptors are present. So we saw that predominantly, like in kidney, 90% of the glucose that is getting filtered from the glomerulus and that reaches the proximal convoluted tubule is getting reabsorbed by this SGLT, which is about 90%. And this is about SGLT1 causes about 10%. What is the reason for this selectivity of SGLT2 and SGLT1? So these receptors are placed, or constituents of these receptors are in such a way that the affinity for glucose with respect to SGLT2 is low. So these are low affinity but high capacity. So what do we mean by low affinity and high capacity? So when they have an affinity of low, so if it reaches the proximal convoluted tubule, when they have an affinity for glucose which is low, it means that they are able to pick the glucose and they are from the lumen and it reaches the proximal convoluted tubule, and from there it reaches the blood glucose, whereby these receptors which are present are free. So when they are free, they can pick up more amount of glucose and they can be again sent to the blood. So this process happens passively or actively. So this process is continuously, it is happening. So these receptors have a low affinity. So when we mean by low affinity, they are able to pick up faster from the lumen. So from the lumen in the proximal convoluted tubule, the glucose are picked up faster, and once they are picked up, they are being shut down to the blood. So they stay in the receptor for a short time. That is the reason these SGLT2 are called as low affinity. So the moment it is filtered and sent to the blood, these receptors are free enough to pick up for another glucose which reaches there. So whereas SGLT1, which are present in the distal portion of the proximal convoluted tubule, like as we said, it is present in the 3 segment. So most of the glucose which has to get absorbed happens only at the level of S1. So 90% of it gets absorbed over here. Only 10% of it is remaining. So the 10% of the glucose which remains in the lumen reaches the S3 segment. So this S3 segment of the proximal convoluted tubule, where SGLT1 receptors are present, they have a high affinity. So when they have a high affinity, they can absorb and retain, because they can they have a high receptor. Only 10% of glucose reaches. So whatever glucose that reaches over there, it can get absorbed and retained there. It doesn't need to send immediately into the blood and all. So since the amount of glucose that reaches it is very minimal. So there lies the beauty how this proximal convoluted tubule has been made. So low affinity for SGLT, but whereas like because that is the advantage. So they have to keep moving from lumen to blood, lumen to blood, lumen to blood, the glucose. So they have to have a low affinity but high capacity. So that is what we mean by low affinity, high capacity. Whereas this SGLT1 has a high affinity but low capacity. So they have a high affinity, whereas high affinity but low capacity. So this is the difference between SGLT1 and SGLT2 receptors which are present in the kidney.